Hello, everyone. My name is Michelle Juma, Project Management Specialist at Shatterproof, as well as representing UNSHAME Kentucky. And welcome to our June webinar, Improving Opioid Use Disorder Treatment for LGBTQ+ communities. Please feel free to introduce yourself in the chat using your name, your organization, or what city you're joining us from. We like to see who's making out our audience and start getting some feedback before you're welcome to answer questions along the way. This event is being recorded and will be available on the UNSHAME Kentucky website. Note that all attendees will be muted throughout the call, but please feel free to use the Q&A features at the bottom of the screen to ask your questions, as well as use the chat box. We will not be moderating the chat closely, but encourage you to use it for any general commentary and to connect with others. The interpreter will remain spotlighted throughout the webinar, but to adjust your view, visit the top of your screen where it says View All Speakers or Panelists, and you'll click one of the features to shift between speaker view and gallery view. There's also closed captioning available for this event. Let me confirm that our captioner is available on screen. As they get settled, I'll turn on the feature and individual will be able to read the bottom of their screen for any spoken words. The UNSHAME Kentucky webinar series is brought to you in partnership with the Kentucky Opioid Response Effort and Shatterproof. We'd like to give a special thanks to the Kentucky Office of Vocational Rehabilitation for providing ASL interpreting services for this event and all future webinars in the UNSHAME Kentucky campaign. Our agenda will look through a brief overview of the UNSHAME Kentucky campaign and then two presentations from some excellent speakers before we go into question and answer and expect to close at 2 p.m. A survey will be available as you close out of the event. But just in case folks might miss it, I'll go ahead and drop it in the chat as well. We really do appreciate your feedback and want to continue to improve the rest of our webinar series. I'd now like to invite Marissa Williams to come forward, introduce herself, and just talk about the UNSHAME Kentucky campaign. Marissa.
Thank you, Michelle. I'm Marissa Williams. I'm the program coordinator at Shatterproof, leading the UNSHAME Kentucky campaign. I'm just going to do a quick overview of our campaign for those that are new to UNSHAME, just to provide a little bit of context. So like Michelle mentioned, the UNSHAME campaign is a partnership between the Kentucky Opioid Response Effort, or CORE, and Shatterproof. It's a 12-month-long evidence-based campaign aimed at the general public in Kentucky, hoping to reduce the stigma that's held against people with opioid use disorder. So the goals of the campaign, we have three very straightforward goals. The first one is to increase knowledge about opioid use disorder, or OUD, and that recovery is not only possible, but probable with support of friends, family, and the person's community. Our second goal is to improve attitudes towards those living with or those that are in recovery from OUD. And finally, we want to develop Kentuckians' understanding of OUD so people can better support their loved ones and community members living with OUD or who are in recovery from OUD. So our campaign has three main pillars. The first is community connection. So we really try to connect with the community by reaching out to different community-based organizations throughout the state. And we also have a community impact committee. So that's 8 people from different backgrounds and different places throughout the state that provide us with feedback on the campaign on an ongoing basis. We really depend on these community organizations and the representatives from Kentucky that serve on the CIC to direct our campaign and ensure that it's effective for all Kentuckians. The next pillar is story sharing. So we collect stories of people in recovery, friends and family, and providers of recovery and treatment services. We found that when people that may not have that direct connection to someone with OUD or someone who's in recovery, when they're able to view a story of a person that's been directly impacted, it really creates connection between those two people. And finally, our last pillar is education. So we leverage those community organization networks to spread our anti-stigma messaging on social media and within their community in person. And we also provide webinars like this one on a monthly basis to provide different lanes of education throughout the campaign as well. And Michelle, I think I'm handing it back over to you.
Yes, you are. I am very excited to announce the newest online offering of the UNSHAME Kentucky campaign, our community website. So this is a free and available to the public platform where we wanted to create an additional space for all of you and all interested parties to connect on anti-stigma work. So we have the relationship with our UNSHAME partners, but this is just going one step forward so that we can have friends, colleagues, advocates, anyone who's really committed to this cause, and give them an opportunity to learn more about the campaign, find out about special events, get involved in message boards or particular groups where they can just connect on similar interests and learn more. You'll find private message forums. We are rolling out a job board unique to the sector, as well as a mentorship program in the next few months. So please stay tuned and feel free to create a profile and start to connect with others outside of just this webinar series. I'll go ahead and drop the link in the chat once more. But I do hope that you'll join us on the journey, and on the homepage of UNSHAME Kentucky, you go ahead and click the join community button and start some really interesting conversations as we continue throughout this process.
Great, thank you, Michelle. I'm so excited to introduce our speaker for today, Dr. Brian Hurley. Dr. Hurley is an addiction physician and the medical director of the Division of Substance Abuse Prevention and Control in the Los Angeles County Department of Public Health. He is the president-elect of the American Society of Addiction Medicine and gives presentations around the world regarding addiction medicine, motivational interviewing, and gender and sexual equality. He previously served on the board of directors of the GLMA, Health Professionals Advancing LGBT Equality, and as the chair of the LGBT Advisory Committee to the American Medical Association Board of Trustees. Join me in welcoming Dr. Brian Hurley, and I will hand it over to him.
Thank you very much. Thrilled to be here. I really appreciated the invitation to speak to improving opioid use disorder treatment for LGBT plus communities. I'm going to trust you can see and hear me unless anybody chimes in and says that you can't. So I'm gonna go ahead and jump ahead.
Looking great.
All right, excellent. My pronouns are he, him, and his, and I don't have any financial conflicts of interest. I am the president-elect of the American Society of Addiction Medicine, and ASAM has topics, including education and practice guidelines related to the treatment of opioid use disorder. And so my comments might be biased towards ASAM and our education and practice guideline products, but again, that's not a personal financial conflict, it's a fiduciary conflict. So I have about 20 minutes, and I'm just going to use that time to speak to the definitions and concepts related to sexual and gender diversity, talk about minority stress and trauma, talk about opioid use disorder treatment, and then wrap up with engaging sexual and gender diverse individuals who are seeking addiction treatment services. There are 4 orthogonal or separate components of the human experience. We are born with a sex development, and for most of us, it's XX chromosomes and XY chromosomes, but there are some variations in our chromosomal makeup, and then additional variations in our sex development, that is our biology and everything from our genitals to our secondary sexual characteristics, how those develop. And that is separate from gender identity. That is how we identify, whether we identify internally as male, female, or some variant. Then there's our gender expression. Gender expression is what people see, everything from our haircuts to our makeup to our dress to how we carry ourselves. And that's also separate from sexual orientation, that is who we're attracted to in our sexual behavior. And each operates orthogonally or separately from the others. There are 3 dimensions of the sexual orientation. There's our sexual identity. Do we internally identify as gay, straight, bisexual, pansexual, asexual? There's a bunch of different sexual orientations. Then there's who we're attracted to, that's sexual attraction. And then there's our sexual behavior, that is what we do sexually with others. And although there can be alignment, there's not always alignment between these 3 dimensions of sexual orientation. Gender identity refers to the experience of our own gender. And the terms that we oftentimes hear is cisgender, when our internal gender identity correlates with our assigned sex at birth, that is, correlates with cultural norms and expectations. Or if there's a difference, it can be called transgender. And there's culturally established gender categories that serve as the basis of the formation of a person's social identity in relation to other members of society. Gender identity is not determined by appearance or observed gender expression. The only way to know somebody's gender identity is to ask. That's why there's been a big push for pronouns, for people to identify, how do you want to be identified, as a way of helping collect information that can be useful for how people want to be addressed. And then there's gender expression. And you can go from gender conforming, that is, your gender identity aligns with the cultural expectations of how people in your gender identity express themselves. Or there's gender non-conforming, which is really an umbrella term whose gender expression or identity or role might differ from the gender norms associated with their assigned birth sex. So here is, if I could offer one slide to encapsulate everything I just covered with terminology, it would be gender identity, that it goes from non-gendered to people have various degrees of womanness or manness in their internal sense of self. Gender expression ranging from agender, that is people who look very neutral and ungendered, to highly masculine or feminine expressions. And again, masculine and feminine are culturally defined. There's biological sex, everything from not having a clear differentiation to various degrees of maleness or femaleness in our biology. And then our attraction, ranging from being attracted to nobody to being attracted to men and being attracted or male identified people, being attracted to women or feminine identified people. And so I would posit this as the back of the envelope, the shortcut to how each of these elements operate orthogonally to the other. And other terms that you'll hear, right? The alphabet soup, LGBTQIA, SA. The A typically refers to allies, that is, people who are cisgender and or straight identified, but who affirm sexual and gender diversity. LGBT is probably the most limited term that we currently use to refer to sexual and gender diverse communities. But you'll see various letters spelled out. So LGBTQIA, which would refer to lesbian, gay, bisexual, transsexual, which is usually a term we don't use much anymore. Transgender is a broader term we use to describe gender diverse communities. Sometimes people use the word intersex, which refers to people that might have a difference in their sexual development. Queer and questioning are also terms that you'll sometimes hear. Two-spirit and allies are also terms that you'll hear with reference to gender diverse communities. How many people identify as LGB and or T? Well, it actually depends. There's various polls, and this is poll data that was published like almost 10 years ago, but it gives a range depending on the polling strategy of the percentages of the population that identifies LGB and or T, and you get it ranges anywhere from 2 to 6%. We estimate roughly 0.6% of adults in the United States identify as transgender. A lot of the numbers regarding transgender populations are suppressed by having a community that's not generally welcoming of diverse gender expressions or gender identities, and the actual number is not fully known. So that's the context and some of the language I'll be using to describe sexual and gender diverse communities. People whose sexual orientation might differ from straight or gender identity might differ from cisgender are more vulnerable to developing a substance use disorder, typically as a result of adverse childhood experiences and context-specific stressors that include lack of positive experiences. Now, this slide covers just the wide range of biochemical and behavioral vulnerabilities to substance use disorders. But the minority stress model is in the social influence quadrant in this vulnerability. What does this mean? Most LGBT people do not have a substance use disorder. So let me be clear. But people who identify as LGB and or T are more vulnerable to developing a substance use disorder. And this is the minority stress model published almost 10 years ago that talks about the relationship between minority status, minority stress, and the processes that impact an individual's risk of developing a substance use disorder. And the mediator between whether somebody who identifies as LGBT goes on to have a positive or negative mental health outcome has a lot to do with resilience. So there is this resilience model among sexual and gender diverse individuals that talks about the importance of social support, emotional openness, and hope and optimism for individuals that seem to lower the reactivity to prejudice and oppression that improves psychological health. So to be clear, LGBT populations, while are subject to more minority stress, does not then mean that every LGBT person has a poor mental health outcome. But interventions that support people's social support emotional openness, that typically means welcoming and acceptance, and that facilitate hope and optimism, future orientation, have a big impact on people's substance use and mental health outcomes. When we look at gender non-conforming individuals and the report of psychological distress, this was a California study looking at the mental health of gender non-conforming adolescents in the state where I live, which is California. And we see a big rise in the increase of severe psychological distress by roughly 10%, which was statistically significantly different than the gender conforming group. So this is sort of a gender conforming group of adolescents, a androgynous or somewhat gender non-conforming, and then a highly gender non-conforming group. And we saw greater rates of psychological distress that the models suggest are explained by lack of social acceptance and not there. It's not like there's this intrinsic connection between being gender non-conforming and psychological distress. It's usually a result of the experience of transphobia and homophobia. If we then look at, well, what does this have to do with opioid use disorder and the opioid crisis the United States is facing? Individuals that identify as LG or B, right, lesbian, gay, or bisexual, which I'll use the blanket term sexual minorities, are at higher risk of illicit opioid use. And it actually varies by category, but you'll see that for women who or women identified LGB individuals, so lesbian and bisexual individuals, you'll notice that there was a significant difference in the 18 to 25-year-olds and the 26 to 34-year-olds, and among the 35 and 49-year-olds. And for male identified populations, so gay and bisexual populations, and the 18 and 25-year-olds and the 50-year-olds, there was some significant difference between LGB identified people and heterosexual people. Again, if we look at illicit opioid use in sexual minorities between male and female populations, looking at bisexual versus gay or lesbian versus heterosexual, again, we do see some significant differences that are more pronounced for women than they are for men. And if we look at racial differences, we see higher rates of difference for white and Black identified populations. But for Hispanic women, we see a big difference, and that difference was not as significant for Hispanic men, interestingly. What do we know among substance use disorders among transgender individuals? We do see a significant difference among transgender and cisgender populations regarding all substance categories, including the opioid use category. And this was a cohort of commercially insured individuals, that is people that had private health insurance. So we did see a significant difference in substance use, again, between transgender and cisgender populations. Again, most people that are transgender do not have a substance use disorder, but are at higher risk of developing a substance use disorder than cisgender populations. But we did not see that significant difference among opioid use disorder for veterans, right? So people that get their healthcare at the VA, that population, we didn't see a difference in opioid use disorder between transgender and cisgender populations. So the evidence that like being transgender makes any individual uniformly at higher risk of developing an opioid use disorder is not universal. It actually depends on the group that you're looking at. And transgender veterans are a very specific community that can't always be generalized to commercially insured populations. So what do we know about treating sexual and gender diverse populations? LGBT clients are more likely to engage in treatment programs that address issues of sexuality and gender. And we know that there's less adherence and less responsiveness with treatments that are recommended by homophobic providers. So homophobia and transphobia is a huge interrupter of the therapeutic alliance, and the lack of accessible treatment for transgender individuals, that is sort of the lack of attention to creating spaces that are gender affirming for people who are gender nonconforming or transgender, is a huge gap in our treatment system. What do we know about treatment in general? Well, the core components of opioid use disorder treatment include meds, plus counseling, plus support. Let me be clear about what I mean by this. I am not suggesting that every person with an opioid use disorder has to receive meds and counseling and support. This is what's on the menu. When we treat diabetes, the menu is meds, diets, and exercise. Now, lots of people with diabetes only take meds and don't diet or exercise. Lots of people with diabetes diet or exercise, but don't take meds. Similarly, it's true with opioid use disorder, but not all three of these treatment modalities are equally effective. The medications for opioid use disorder, and this is a slide covering all of the FDA-approved meds for tobacco, alcohol, and opioid use disorder, but the upper left quadrant, the opioid use disorder meds, seem to have a huge impact on people's remission and recovery from opioid use disorder. Now, there are counseling strategies that are also effective. And a lot of these counseling strategies have been tested in non-opioid use disorders. And to be clear, I want everyone with opioid use disorder to get meds and counseling and support. But counseling alone in the absence of medications does appear to be significantly less effective than meds plus counseling. And the meds, even without counseling, have a strong impact. So MOUD, medications for opioid use disorder, remain critical to addressing opioid use disorder, and that is not different than among LGBT populations. So if I have an LGBTQ identified person, I'm still going to prioritize access to medications for opioid use disorder to address their health and wellness. But to get them on medications for opioid use disorder, I have to attend to anything that's going to interrupt the person's readiness and therapeutic alliance. So that means asking for pronouns. That means integrating behavioral health and using trauma-informed approaches, given the higher rates of trauma experiences among LGBT populations, and to apply minority stress principles in order to address any barriers for people getting on MOUD and the remainder of the package of opioid use disorder treatment. And we don't really have a ton of research to explain how LGBTQ specific treatments relate to opioid use disorder treatment. We have some research on LGBTQ specific treatments for treatment in general, but for OUD specifically, the more research is really needed. So this is a model published in 2018 from my colleagues at the Fenway Institute out in Boston. So if the basic principle for opioid use disorder includes coping with cravings or shoring up motivational commitment or refusal and assertiveness skills and coping plans, We can adapt these for sexual and gender diverse populations by talking about minority stress specific triggers, by talking about discrimination and managing anticipated discrimination in the community, by talking about substance use disorders as a barrier to personalized goals, which might include things like PrEP or other HIV prevention strategies. And for transgender patients, assertive substance refusal skills with maybe non-transgender sex partners, which can oftentimes be a trigger for use. And for cognitive processing therapy, the basic principles for like PTSD include psychoeducation, impact statements, maladaptive thoughts. So how do you tailor that for LGBT populations? Well, focus on how LGBTQ specific stigma exacerbates PTSD, attributing challenges to minority stress rather than personal failings. I can't tell you how many of my own patients I talk to, like, having a substance use disorder is not your personal failing. It is not entirely your fault. There are roles for individual responsibility, but people sort of over attribute themselves as being bad or worthless and typically in response to having a substance use disorder. Now, increasing numbers of treatment programs are offering LGBT specific treatment categories, with the exception of opioid treatment programs, right? And I mentioned medications for opioid use disorder seem to be have an outsized effect in supporting remission, and yet OTPs, which are the only entities federally licensed to administer methadone to people with opioid use disorder, are roughly twice as less likely, right? So half as likely to offer LGBTQ tracks, and a lot of that has to do with how they're funded and structured. And what do we know about LGBT specific treatment? There's been a lot of focus on treatment outcomes among gay men and less of a focus on other sexual and gender diverse populations, and mostly focus on client attitudes and acceptability of treatment. The outcome studies do not say that LGBT patients have to go to an LGBT specific track in order to have a positive outcome. So here's a study from Steve Shepta that's 15 years old now, that compared a culturally tailored gay specific group to CBT versus contingency management versus a combination. And all groups actually showed significant reductions in drug use. And there wasn't a difference among the gay specific CBT group versus the other modalities for the gay and bisexual men who participated. There's another study about the same group that compared gay specific CBT and gay specific social support therapy. And again, both showed significant reductions in use. And comparing motivational interviewing with CBT in a group of men who have sex with men with alcohol use disorder, again, both types of therapy seem to work. So this suggests that treatment of LGBT individuals does not require LGBT affirming treatment. And good clinician, LGBT individuals can have a good outcome with treatment as usual, provided that the treatment as usual is reasonably free of homophobia, transphobia, and heterosexism, where patients are held in positive regard, where there's openness about sexual orientation and gender identity, and where the people doing the treatment are familiar with the issues faced by LGBT people. And where programs, I think, do have a role is people who are, their substance use is struggling with their coming out, where people might not be comfortable being open about their personal lives, for people for whom their conflict about sexual orientation or identity is a big driver in their substance use, trauma victims of homophobia or transphobic attacks, or people for whom their drug-associated activities, such as sex, might be difficult to discuss in a general population setting. So I'm going to wrap up now. This is the reference on the National LGBT Education Center's Addressing Opioid Use Disorder and LGBTQ Populations Guide. This is the ISAM, International Society of Addiction Medicine textbook that includes a chapter on LGBT populations. This is an older guide, but it's SAMHSA's guide on substance use treatments for LGBT individuals. And this was a guide that I helped with the Association of American Medical Colleges on implementing climate changes to improve the health and wellness of individuals who are LGBT, gender nonconforming, and or born with a difference of sex development. This is my email address, and I will go ahead and stop sharing my screen now. Thank you very much.
Thank you so much, Dr. Hurley. That was very informative, and I know that our audience is probably going to have a lot of questions on that. Thank you to those of you that have already started using the Q&A function below. If you have any additional questions on Dr. Hurley's presentation, we'll be answering those a little bit later on in the webinar. So I encourage you all to submit your questions there. So to introduce our next speaker, Erin Guldenschuh. Erin has worked at the Recovery Café in Lexington for 1 year, focusing on equity and inclusion for racial, ethnic minorities, and LGBTQ+ individuals. Educated in theology, his master's thesis, Strange God, A Biblical Theology of Queer Liberation, explored queer and queering narratives of the Hebrew Bible and made applications to contemporary queer experience through an intersectional lens. Erin has worked in nonprofits in outreach, case management, and leadership roles. Erin is in long-term recovery and is grateful for 5 years of his continuous recovery. Erin, I will hand it over to you.
Thank you so much. I appreciate that. And I'm so grateful to be here and to have the job that I have here at Lexington, Kentucky, at Recovery Café Lexington. I just wanted to share today briefly about visibility and how we can make our recovery community centers and treatment centers more accessible for people who are LGBTQ identified. So here we go. When I think about inclusion and what it means to welcome people and visibility, I think about what I value in a provider. And I invite you to do the same while we're thinking about these questions. What is it we value? How do our providers, medical providers, mental health providers, faith communities signal inclusion of us? So, you know, I'm looking for competence, for empathy, for a sense of hospitality, for kindness, for patience, for judgment-free care. As a queer person, if I'm going to take care of my sexual health, am I worried that a provider may judge me because they don't like they don't welcome LGBTQ people, or they might have a judgment about the number of partners, or whatever the things that make people feel vulnerable in a situation, in a clinical situation. Also looking for a sense of belonging and basically feeling seen when I'm entering a space. And then here, visibility for our consideration over the next couple minutes is why visibility matters, how visibility communicates inclusion, and then some of the things we do at Recovery Café Lexington here in Kentucky to provide, to signal inclusion for those who access our services. So visibility matters because it signals welcome, it reduces barriers, and it also provides an opportunity, if there's trainings in place, for increased competence in our service providers. Signaling inclusion for LGBTQ communities, individuals and communities increases the likelihood that those individuals will access our care and services. Visibility also, when we create visibility and inclusion for other people, even if they're not our intended audience, it makes other people more free to be themselves and to feel included. And I'll touch on that in a little bit. And then, you know, some ways that we can show visibility for LGBTQ people is by having pronouns in our signatures, by having an updated LGBT pride flag, by signaling that our spaces are safe, gender inclusive restrooms, and of course, training for our staff. We can't expect our employees and service providers to know what they don't know. So providing, investing time in training staff on LGBT inclusion is really important. And also thinking about the way we conduct forms, I mean, our enrollment forms and the surveys we produce internally. Those also signal inclusion. If there's just two choices for gender, that's already signaling that there may not be space for people who don't fit within that binary. Visibility is actually more than just you know, target turning. It's logo into a rainbow or another corporation or posting on social media. It involves that, but it's really about creating space for people to be themselves. A lot of times I've grown up in the South. I grew up in the South. I've lived in the South my entire life. I have a lot of well-meaning colleagues who have said, well, we don't discriminate. We practice kindness. You know, all lives matter. Everybody's welcome here. We don't really need a pride flag. And then posing questions like, isn't it discrimination to promote one group over another? And so my challenge out of my own, personal experience would say, in our culture, where we are predominantly white, predominantly heterosexual, predominantly cisgender, that it's important to provide space for people who are disproportionately affected, as Dr. Hurley has articulated, disproportionately affected by substance use disorder or the other social ills like poverty and other vulnerabilities. So signaling inclusion does not mean exclusion for other people when we're building the community that we want. Visibility speaks to someone's lived experience. It signals that you're welcome here. Visibility is like having insider knowledge about how people are welcome. I remember growing up with evangelical parents in the Deep South, that at certain restaurants or car dealerships or whatever, there might be different symbols that were used in advertising, and that was like inside speak. It like said, hey, we believe these certain things, and these are our values. And I think that the same could be true in community centers like where I work, that we use symbols and insider knowledge to create hospitality for people who need our assistance. Some of the things that we've done here at Recovery Café Lexington is we do have LGBTQ safe space signs, both in our common spaces, but also in the space that we share with or not rent to, but provide for 12-step meetings. We have pronoun markers on our staff badges and in our emails and in name tags. We offer pronoun markers for people when they come in to self-identify, pins that they can attach to their lapel. We have mandatory training for LGBTQ inclusivity and trans inclusive workplace training. We've wrestled as a staff with some of the tough questions and invested a lot of time and significant money in helping people understand that this visibility and inclusion is not really just about making people feel comfortable. It's really about saving lives. We have all gender restrooms. We have pride flags displayed, but particularly outside, we do during Pride Month. Our enrollment forms are inclusive, and we've also written grants to allow us to reach out to LGBTQ people who are of racial and ethnic minorities. And we have executive level LGBTQ staff. So investments in people are really important for creating the space and reaching the people who need our services. Some of the outcomes that we have is that for our first ever drag show in February, we had 288 people who attended. At our drag show that was just last week, we had 187. We've had increased community collaboration because people see because I believe people see what we're doing and want to be a part of that, and it's helped to model inclusivity maybe in the community. We're partnering and with AVOL to do a weekly, AVOL is AIDS Volunteers of Lexington, which is a HIV provider here in Lexington, and they're going to be present with us every Friday to do testing for Hep C and HIV and provide HIV prevention services. We have noticed among our members that's what we call our clients, our members, that when after we've started these initiatives of being more inclusive, people have started to self-identify in ways that they didn't before. People have felt freer to tell us what they want their pronouns to be, whereas before they didn't know that they could be that this was a safe space or didn't feel as safe. And so people have said, oh, well, actually my pronoun is they, or actually my pronoun is he or she. And so when we created that those initiatives, it created more freedom for people to be themselves. And then two things, we had a member who is trans who actually initiated having this most recent drag show and led that, organized the community partners to be on site, and felt really empowered. And as a result, a person who's heterosexual, white, and cis wrote on social media and tagged us in the post that they felt empowered to come out, and they were coming out not as a lesbian, but as a person who has substance use disorder. And that just hammers home, at least anecdotally, the point that when we create an inclusive space for minorities, sexual minorities, or racial ethnic minorities, we actually free other people too to be more themselves and empower them to tell their story and to live the lives that they want. Thank you so much for your time and allowing me to be here with you all today.
Thank you so much, Aaron. Really loved your presentation and sharing what you all are doing at Recovery Café Lexington. It sounds like you all are doing great work. So like I mentioned, after Dr. Hurley's presentation, I encourage you all, if you have questions on anything that Aaron presented, to please use the Q&A function on the bottom of your screen to ask those questions. So to start off, Dr. Hurley and Aaron, with this Q&A. So Aaron, you shared a lot of different things that Recovery Café Lexington does to make your space inclusive for people of the LGBTQ+ community. But what improvements can other recovery community centers or treatment facilities or recovery housing do to make sure that their spaces are truly welcoming for LGBTQ+ individuals? Maybe they're just starting off trying to make their space inclusive. What would you recommend to them?
I would recommend starting with basic signage. You know, I think stating that the space is safe, and investing the time in explaining, getting the staff on board to make sure the space is indeed safe, and that this is you know, patient-centered or consumer-centered, client-centered care, that this isn't about my personal beliefs, it's about meeting the person where they are and making sure that they have access to the things they need. So I would say signaling through signage. I would say investing in staff training, because people don't know what they don't know, and we can't make assumptions that one's individual experience with LGBTQ people or a friend or family member is actually a universally, you know, the way that we up to date, the way that we actually kind of do things in a treatment or a service providing setting. And I think pronouns in emails are really important, and explaining why that's important. Looking, you know, when you look at your space, wherever that is, you can ask yourself, what does this space say? And so if every picture on the wall is a man and a woman together, or all white people, or there's Bible verses on the wall, but there's not other faiths symbols or wisdom on the wall. You know, I think looking at the space and seeing what it communicates, having an honest assessment of what that space communicates, and then thinking of ways to deliberately communicate inclusion of people who are LGBTQ.
Great, thank you. Dr. Hurley, did you have anything to add there?
The only thing I was potentially going to add is to have a system of asking people what their pronouns are. And whether that's through signage, whether that's through intake forms, but having a open-ended system for asking people about their pronouns is a strong signal for welcoming communities that are gender diverse.
Yeah, absolutely. Thank you both for your feedback there. So now kind of looking in the opposite direction, so kind of outside of these obvious flags, what are some red flags that may make an LGBTQ plus individual not feel welcome at a recovery community center, treatment facility, or recovery housing?
One of the biggest factors over how welcoming or unwelcoming a setting is the language that people use. So I started my part of this presentation by talking about terminology, because there is terminology that I've seen and heard used in treatment programs that can be a big turnoff, particularly, and I think Aaron mentioned signage and images and what's the race of people, what's the sort of perceived sexual orientation of people. But being attentive to using updated terminology and having a process for when staff or peers are using language that is threatening or distancing or invalidating, that there's a particular attention among organizational leadership to the language that's used in their treatment program.
Aaron, any additional thoughts there?
I think that unfortunately, religious symbols can sometimes be a trigger for trauma for people who have been, I don't know, harmed by religion. And not all religion's bad, obviously. So I think sometimes a red flag to me might be a religious symbol and exclusion of all others, or a particular kind of conveyance of that. But yeah, I think language, if someone says, oh, so you're a homosexual, I mean, that language be upsetting to me. Yes, up-to-date language, all of that Dr. Hurley covered.
Great, thank you both. We have a question that says, for treatment facilities or recovery houses that do not have bed assignment policies, are there recommended resources for staff to utilize in order to create such policies that are welcoming to individuals of LGBTQ plus communities?
It's been a while since I've looked at it, but I would refer to the SAMHSA guide on providing treatment to LGBT communities. Speaks to some of the housing considerations, and that include bed assignments. I've always, when I've seen treatment centers struggle with this, it's typically when the treatment center is trying to make decisions anticipating or on behalf of an individual patient or client, as opposed to with them. So having an open and honest conversation of these are our options, where would you feel more comfortable? This is what and just outlining this is what the milieu is like, to help somebody make an informed decision of how to access treatment, I think would just, that itself would be a huge step. And then, as Aaron mentioned, in staff education, to make sure that the leadership is aligned with what actually the staff are doing in the residential site.
Definitely. Thank you. Aaron, did you have anything additional there? Otherwise, we have a couple more questions. Great. Another question we got from the audience is, what advice do you have for providers concerned about legal ramifications related to recent legislation and their rights to provide gender affirming treatment?
I'm not an attorney, and there is absolutely no legal consequence that I'm aware of addressing somebody by their preferred pronouns, housing them in the site that they determine to match with their gender identity. Like, supporting and identifying with people is in no way against the law. There are states that are passing laws around, sort of age requirements or consent requirements around LGBT, or I should call them like transgender affirming care, whether those are hormones or surgical procedures. But a treatment center, generally speaking, is not in the position of delivering those gender affirming treatments. Typically, a treatment center is in the process of supporting people and facilitating people's health and wellness. And there's nothing, but no organization I'm aware of any legal risk to use the pronouns people need to, that they identify with, house them where they're comfortable, meeting somebody where they're at. Those are all part of just good, effective treatment that doesn't put, even with increasing state scrutiny over gender affirming care, I'm unaware of any like specific legal risks of treating people with compassion to humanity.
Yeah, I think that's a great answer. Erin, any additions? Sounds good. Another question kind of related to what was asked before. So since safety is a factor for LGBTQ plus individuals seeking treatment or recovery housing, do you two believe that there should be recovery housing or facilities made available only to the LGBTQ plus community?
I think there's a role for LGBT specific congregate sites, whether those are residential sites or recovery bridge housing or sober living sites. I don't necessarily think the entire organization or the entire housing site has to be like siloed in order for that to be effective. Larger residential or congregate sites can have a section of housing, right? So I don't necessarily, but as long as there's a space where people can effectively engage in care, and it's going to be arranged. There's going to be people who are LGBT that say, I have no need for sexual orientation or gender identity specific housing. There's some people that for whom that's going to be very important for them to have a space where they are free from homophobia, transphobia, where they can recover. And having the option for LGBT specific housing is important, even though not all LGBT people are going to need LGBT specific housing. But I also don't think that means that like you have to have an LGBT only, like there's different ways to accomplish that. It could be part of a house or part of a residential. It doesn't have to be an entire organization.
Thank you, Dr. Hurley. Erin, I would love to hear your perspective on this.
Yeah, I would say that while resources might be tight and it might not be possible to create congregate housing or a portion like Dr. Hurley has outlined, it's also important just to make sure that, or to kind of cultivate among residents or people accessing treatment, also mutual respect for other people. That sometimes we, the fingers pointing at myself, also don't do a great job of like cultivating changed minds or helping people have the opportunity to engage with people and have personal experience that lets them know that to see other people with their full humanity. So I think also carving out space for people to change their views or at least treat other people with dignity and respect is really important in those settings, because I have lots of anecdotal information about how you'll have a gay person who's in or a lesbian or a trans person or someone who's bi, whatever, who's in a house and who endures homophobic and transphobic language, but they don't have a lot of other recourse because it's sober living and they need to put that resource. So I think that creating the space for other people to treat their peers with respect is important.
Great, thank you. Really appreciate your perspective there. Last question before we hand it back over to Michelle. So we have a lot of, friends and family of people in recovery or who are living with OUD on this webinar right now. So what can family members and friends do to support their LGBTQ plus loved ones throughout their long-term recovery?
We've talked about how treatment providers should use person-centered language to seek to understand before they're always being understood. And I think a similar set of principles would work with the families. The families are oftentimes, where I see families get into trouble is when a parent, a sibling, aunt, uncle, whomever, has an expectation of somebody with respect to their gender or sexual orientation, and that expectation isn't met and they can't let it go. Families can learn a lot from acceptance, right? Like just you might aspire, you might hope for somebody to have one trajectory, but in fact they have another. In addiction treatment, we practice a lot of acceptance with our patients and our clients. Supporting families having acceptance for where folks are is probably a place to start. And then sexual and gender diverse training so that people can learn to not just accept, but to embrace, to celebrate, right? The diversity of sexual orientation and gender identities that exist in the world.
I agree with everything Dr. Hurley said, and also that like a recognition that while they may be your family member, they're still part of a broader community with different cultural norms too. And so cultural competency around what it means to be LGBTQ identified in the US or whatever the context is kind of important, that that we may not know everything about our family member because the assumptions we may be making may be with those assumptions that Dr. Hurley talked about and expectations. So giving space for the fact that this person belongs to a broader community as well.
Well, thank you both so much for your answers to those questions and the presentations that you both gave. Very, very helpful and enlightening. So appreciate you both, and I'll hand it over to Michelle.
Thank you, Marissa, and thank you, Dr. Hurley and Aaron, for your presentations. A version of this deck will be available on the UNSHAME Kentucky website, but I just did want to go over a few additional resources that might be helpful. Please consider visiting Shatterproof's Addiction Intersecting Identities page that just became live this month, where we include links to additional educational resources that highlight how LGBTQ+ and BIPOC communities are uniquely impacted by addiction, and also highlights where more research needs to be done to help these marginalized communities. I'll go ahead and put a link to that in the chat. And another plug for our upcoming webinar at the end of July, Minding Your Bedside Manner, Caring for Patients with Opioid Use Disorder. This is a partnership with the Kentucky Hospital Association, where we'd really like to dive into the experience of those who may have been negatively affected by the stigma that exists within the healthcare sector, and start to talk more critically about how providers can care for their patients and they can be more responsive as that first point of contact when people begin their ongoing journey or long-term recovery. Including a link to register for that event in the chat as well. And finally, another thank you to all of our attendees, a thank you to our interpreters, our captioner. We are so grateful to put on events like this with your support, and hope to see you all at our next event. Please be sure to complete the survey that'll pop up on screen as we close out. Once again, my name is Michelle Juma, happy to be putting these on for you. And I'll leave the chat going for a few more moments for anyone who wants to add in any final comments. But thank you so much. Have a great day.